Hi everybody, in this video we'll be talking about aortic aneurysms and dissections. First off, let's start with a little bit of anatomy. So the aorta is mostly a retroperitoneal organ and is located slightly more to the left side of the body. Because it is a large blood vessel, we can divide it in different sections. First, we have the thoracic aorta, which originates from the left ventricle and travels downward to the level of T12. The abdominal aorta begins at the diaphragmatic hiatus and travels down until it divides into the common iliac arteries. The thoracic aorta then can be subdivided into different sections. First, we have the ascending aorta, which is the section branching off the left ventricle and terminates just proximal to the left subclavian artery. Distal to the left subclavian artery to the diaphragmatic hiatus, we have the descending aorta, and then, like we stated before, is the abdominal aorta. An aneurysm occurs due to weakness in the vessel wall and involves dilation of all three layers of the aorta, that is the tunica intima, the tunica media, and the tunica adventitia, of more than 50% of the normal aortic diameter or more than 3 centimeters. An aortic aneurysm can occur anywhere along the aorta. We can have ascending aortic aneurysms, descending aortic aneurysms, and abdominal aortic aneurysms, which are more common just below the level of the renal arteries. Some of the risk factors associated with the development of aortic aneurysms are male sex, age greater than 60 years of age, atherosclerosis, hypertension, smoking, having a first-degree relative with an aneurysm. But some of the things I want you to pay attention is tertiary syphilis, genetic disorders such as Marfan syndrome, which is a fibrillin defect, Ehlers-Danlos syndrome, which is a collagen defect, Turner syndrome due to corrosion of the aorta, bicuspid aorta valve. So for your exams, remember risk factors are going to be smoking is a big one, tertiary syphilis, and Marfan syndrome. Aortic aneurysms are usually asymptomatic. When symptoms are present, they can include an abdominal bruit, a pulsating abdominal mass, epigastric pain or discomfort, and abdominal or lower back pain. Going back to anatomy, remember that the left recurrent laryngeal nerve loops posterior under the aorta arch, so any ascending thoracic aneurysms can compress the laryngeal nerve, and that can lead to other symptoms such as cough, hoarseness, or aphonia. So just keep that in mind. When it comes to imaging, ultrasound is going to be usually the initial step. In addition, we can also do a chest X-ray for thoracic aneurysms, which may show widening of the mediastinum. CT angiography with contrast is going to be confirmatory and diagnostic of an aortic aneurysm. For your exams, you need to remember the screening recommendations, which at the moment when I'm making this video, it is one-time ultrasound in males between 65 and 75 years of age who ever smoke, and also those individuals with Marfan or Ehlers-Danlos syndrome. Management of an aortic aneurysm is going to be based on the size of the aneurysm. So anything between 3 and 5.4 centimeters is just going to be observed. We're going to do follow-ups with ultrasound. We're going to encourage smoking cessation. We're going to control the blood pressure with beta blockers or calcium channel blockers. And for the cholesterol, we're going to be prescribing statins. For your exams, you need to remember that any aneurysm more than 5.5 centimeters in males or more than 5 centimeters in females, at that point we can suggest elective surgery. Anything bigger than 6 centimeters, then at that point we're going to suggest or advise surgical repair. In addition, you need to remember to advise your patients to avoid any heavy lifting or straining to prevent any dissection or rupture of the aneurysm. Complications of an aortic aneurysm include aortic dissection and aortic insufficiency. An aortic dissection occurs when there is a tear in the aortic intima, causing a separation from the medial layer and therefore creating a second or false lumen. Thoracic aortic dissections are classified based on the Stanford and the Becky classification. Type A is going to be for ascending aorta dissections. So A for ascending and type B for everything else. Risk factors associated with aortic dissection include having an aortic aneurysm more than or greater than 5.5 centimeters in diameter, chronic hypertension, connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, bicuspid aorta valve, corrosion of the aorta, amphetamine use, and cocaine use. Trauma can also cause rupture of the aorta. This most often results from a deceleration injury, like in a motor vehicle crash or falls. The most common site of rupture is at the aortic isthmus, which is just distal to the left subclavian artery. This is because at this site, the ligamentum arteriosum is strongly attached to the aorta. So during a deceleration injury, this area is more prone to tearing compared to the other parts of the aorta. Also remember that the ligamentum arteriosum or near the ligamentum arteriosum is the location where coarctation of the aorta most commonly happens in individuals who have Turner syndrome. Thoracic dissections may be asymptomatic, but usually individuals are going to be presenting with sudden, severe chest pain with radiation to the back. Depending on the location of the thoracic dissection, they might also present a variation in pulse. The blood pressure in the right arm might be different from the blood pressure in the left arm. Abdominal dissections are going to be presenting in a similar manner. So individuals might complain of sudden severe chest pain or abdominal pain radiating to the left side, to the groin, the scrotum, the back, a pulsating mass. I want you to pay attention to hypovolemic shock because this is going to be a clear indication that a dissection has occurred and it's going to be presenting with hypotension, tachycardia, and decreased level of consciousness. So some of the three might present, sometimes not all of them are going to be present in your exams, so just pay attention to that. A chest X-ray may be helpful with thoracic aneurysms, and if we do it, it may show widening of the mediastinum and enlargement of the aortic nave or displacement of the trachea from the midline. However, widening of the mediastinum is not specific to thoracic dissections. It can also happen due to hypertrophy secondary to congestive heart failure. Therefore, a chest X-ray is not going to be in a specific finding for aortic dissections of the thorax. Remember, the aorta lies posterior to the esophagus, so a transesophageal echocardiogram or TEE is going to be the best imaging modality to visualize aortic abnormalities such as dissection or aneurysm. This is going to be also the best imaging modality for those patients who are unstable. If your patient is stable, meaning there is no hypotension, there is no severe pain at the moment, there is no tachycardia, then one of the things that you can use to confirm the diagnosis of an aortic dissection is going to be a CT angiography, which again is going to show the true and false lumen. But remember, we can only use this in patients who are stable, nobody else. When it comes to management, the initial step is always going to be your ABCs: airway, breathing, circulation, pain control, IV fluids, blood transfusion, vasopressors, stuff like that. Then after that, you need to remember the different classifications because treatment is going to be based on that. So for ascending aortas or ascending dissections and abdominal dissections, what you need to do immediately is an emergent endovascular or open surgery repair. It is important to know that for individuals who have Marfan syndrome or any connective tissue disorder, an endovascular surgery is not recommended. So, but surgery is going to be the answer for type A and abdominal dissections. Now, for type B, that one we're going to manage that different. So we're going to manage it with blood pressure control. That is going to be with beta blockers. For your exams, remember what are the contraindications for beta blockers: asthma, COPD, bradycardia, heart failure. So if your patient presents with any of those contraindications, then you can use calcium channel blockers such as diltiazem or verapamil. Also, in addition to the beta blockers or calcium channel blockers, you can use nitroprusside to maintain a systolic blood pressure between 100 and 120 milligrams of mercury. Complications of aortic dissections are going to be aortic rupture, cardiac tamponade, MI, aortic regurgitation, and thrombi formation. So just as a summary, remember for aortic aneurysms, the risk factors are going to be males, age more than 60, atherosclerosis. For your exams, remember smoking is going to be a big risk factor, tertiary syphilis, Marfan syndrome, and bicuspid aortic valve. Remember for your exams that the current recommendation for screening is a one-time ultrasound in males aged 65 to 75 who ever smoke, and also for those individuals who have Marfan or Ehlers-Danlos syndrome. Management is going to be based depending on the diameter of the dilation. So anything between 3 and 5.4 centimeters. Just control the blood pressure, control the cholesterol, encourage smoking cessation, do follow-ups. But if the aneurysm is more than 5.5 centimeters in males or more than 5 centimeters in females, then at that point we can opt for an elective surgery. Anything bigger than that is going to need a surgical repair. For aortic dissections, remember that they are usually going to be presenting with sudden severe chest pain, abdominal pain, radiating to the back, to the flank, to the groin, to the scrotum. It can be radiating pretty much anywhere. For thoracic dissections, remember that a variation in pulse might be present depending on the location of the dissection, whether it is ascending or descending. Pay attention to signs of hypovolemic shock, such as hypotension, tachycardia, decreased level of consciousness. For imaging, remember that a transesophageal echocardiogram or a TEE is going to be the best diagnostic tool, because we can also use it in those who are unstable. If your patient is stable, then at that point you can use a CT angiography with contrast, but remember they have to be stable. Management of abdominal and type A or ascending dissections is going to be an emergent endovascular or open surgery repair. Type B, we're going to control the blood pressure with beta blockers or calcium channel blockers, and we can add also nitroprusside. So thank you so much for doing this review with me. If you have any questions or any suggestions, please leave me a comment below. Thank you.